Right. Thank you so much. Thank you for inviting me to discuss about this very important topic. And thank you, Dr. Malika, for setting the stage for this topic. Discuss about why, as prescribers, why this venture of optimizing antibiotics is important, and some practical tips of how we can contribute to this noble activity. So who are prescribers? So we should identify at some point we might be prescribers, but it can be a general practitioner, a mainstream clinician, or it can be a house officer, maybe in the ward or in outpatient department. But also there is other access in our country that people can buy antibiotics from as over-the-counter drugs as well. So we need to think about these aspects, and we must consider all of us as prescribers and attend to this. So what can we think as a prescriber? How can we be mindful about antimicrobial resistance and take some action on it? So first step is be mindful about antimicrobial resistance in your clinical practice. Because if you're not aware, if you're not mindful what is happening around and what AMR doing to your clinical practice, you might not take steps to counteract and fight AMR. So I have listed some of the indicators that I find it useful. It might be best to look at the percentage of patients who are on meropenem and piperacillin tazobactam in your ward, and look at the number of cases of hospital-acquired infections and number of patients who is on antibiotics and developing antibiotic associated diarrhea, and number of drug-resistant culture reports that you see, and patients who are dying despite being on broad-spectrum antibiotic. If you have an idea about these factors, you might be aware that AMR is there in your ward, is there in your clinical practice, and you will be mindful to take steps. The second thing as clinicians, what we can do is use the antibiotic chart. So this is an important thing that the College of Microbiology has devised in the recent few months. So we have a dedicated antibiotic chart, as Dr. Malika said. So why do we need a dedicated antibiotic chart is antibiotic are a special group of medication. You should treat antibiotics with respect, because that is one of the only medication that can have resistance. If you prescribe a metformin or if you prescribe enalapril, you don't expect the patient to become resistant for that medication. So treat antibiotics as a special group, therefore fill this antibiotic chart. So this antibiotic chart should be filled, and you have attend to all the fields of the chart, and nurses and doctors collaboratively can fill this chart as well. And specifically, the antibiotic review should be filled by a doctor. And there are a lot of other things that are important: patient identification, allergy to antibiotics, indication for antibiotics should be clearly documented, and send blood cultures and urine cultures, and that should be documented there. And also, importantly, the antibiotic review is important. So we all like to be smart people. So why don't we apply to that for the antibiotics? So start antibiotics smart. So we have a important guideline that is launched recently, the college antimicrobial guidelines in 2024. So we can refer easily to this antibiotic guideline and be smart. What does it mean by being smart? So remember this term, start smart and focus. Being smart is you are starting empirical choices of antibiotics, which will cover most of the organisms that you come across in a given infection. So you're being smart, you are being safe. But after you control the infection, you are now focusing on the antibiotic choice. So you can optimize the antibiotic by going for a narrow spectrum antibiotic, guided by the clinical results and also the culture reports after 48 to 72 hours. This is why our antibiotic review is very important to us. So to being smart, start on guideline-directed antibiotic therapy for conventional infections. As an example, cellulitis, you treat with flucloxacillin, which is the gold standard of treatment. But also, being smart, you have to think about the severity of infection. Because you might come across a patient who is critically ill, who is in septic shock, who is in immunosuppressive state. So these patients will need a broader spectrum antibiotic to make them safe and to save their lives first. So usually I have given a rough guidance. A respiratory escalation, you can use piperacillin tazobactam. And you can, for the urinary source, you can roughly use meropenem, as there are a lot of ESBLs in our setting. What else can we do as prescribers? Early source control is very important. Source means where the infection starts with. It can be starting from the kidney as a pyelonephritis, starting from lungs as a pneumonia. So you must control the source. How can we do that? So source control of infection is important because it reduces the severity of infection and reduces the duration of antibiotics and also reduces the hospital stay. So the patients can go home early. This is very important. So we have to proactively look for the source of infection. It is being more active than being active. So being proactive. So if there are sources that are given below, obstructed infected system, a pus collection or an abscess, if there's anaerobic collection, an empyema. So in these certain situations, you must ask for your colleagues, surgeons, or whatever the specialties that you come across, urologists, etc. And you must control the infection by controlling the source. You drain the abscesses, you decompress the infected system, you open up the anaerobic pockets, and you have a better control of the infection. And you are basically saving the life of the patient and sending the patient home early. If you don't do this, if the source control is done inadequately or is it delayed, you are doing ineffective escalation. You might be happy that you are escalating the drugs for meropenem or piperacillin tazobactam, etc., but you are not doing an effective exercise because the antibiotics won't reach the site of infection. Because the best way to do is you do the source control and then let the antibiotics work. So early source control, everyone, is very important. So it is important for the cost as well. So the patient would have a shorter hospital stay. I'm giving you one example that we had recently, an uncontrolled diabetic who admitted with an unhealthy toe. And he had, as given in the picture, you can see that there is a source which was not visible initially. There is some pus collection which is tracking down to the fifth toe. But unfortunately, initially, an amputation was done, wound pilot was done, but this was not attended. So then you could see from the blue line, we have escalated these antibiotics for the meropenem. But we can't expect the meropenem to work properly unless we drain these collections. So mind you, look at these important points and do the source control early so that you are giving a better chance for the antibiotics to save lives. What else can we do? Antibiotic review after 48 to 72 hours. This is a very important step because we don't have to unnecessarily give antibiotics for people, and we don't have to give unnecessarily long durations of antibiotics as well because we are inducing antimicrobial resistance. You might not see that effect immediately, but you will see in another few years or 10 years or something like that, and we'll be in deep trouble. So what can we do for the antibiotic review? So go through these important steps and you are doing the antibiotic review properly. So make or review the diagnosis, whether it is an infection or a non-infectious condition, whether it is a viral or bacterial, and then confirm the diagnosis and confirm the source of infection. So go through these 3 steps and make the diagnosis. And then you initially send blood cultures and urine cultures being smart before starting antibiotics. But then you have to trace the blood cultures and urine cultures and see what is the results of that, because you can take actions for those results. And then we see whether the appropriate antibiotic is given, appropriate dose, and the route is given. Then you go to the patient and assess the patient properly and do a daily overall assessment. Mind you, anything that you see the patients daily, and you assess the patients daily for the antibiotics, do a specific daily assessments when in your antibiotic review. And then you plan on changing or optimizing antibiotic, either escalation of antibiotics or de-escalation of antibiotics. So usually this 48-hour review should be performed by a medical officer. But if there are any concerns, you can always discuss with your senior or a consultant. So what are the components of the daily overall assessment? This is very simple and straightforward, and even a doctor or a nurse or any other healthcare professional can be able to do it. So first step is seeing whether the patient is clinically improving or not, or improving or deteriorating. So just one question: are you feeling better than yesterday? Is the appetite better? And have you started eating and drinking? If you just ask these 3 questions, you can get and gauge whether the patient is improving or not clinically. And second step, you look at the vital signs, the hemodynamics. How is the blood pressure? How is the ventilator requirement? How are the inotropes? Are they tailing off? Oxygen requirement is reducing. So you can get a gauge of the hemodynamic and the vital signs. And then examine the patient properly. Look at the physical signs. Listen to your lungs, and listen to, look at the cellulitis, where the skin is wrinkling. So you elicit these physical signs and see whether the patient is clinically improving or not. And then look at the source, where the source is adequate control. If there's an infected obstructed system in the biliary tract or urinary tract, has it been attended to? Has it been drained? Has the stone been removed? Has the abscess been drained? So you attend to this source and see whether it is dealt with. And also see whether all the plastic material is removed. If the patient is on an unnecessary catheter, if the patient is on a cannula or in a central line, can these be, are we still using it? If not, you can remove this plastic material, because these are a great nidus for bacteria to grow and cause further infection. And then whether the diagnosis is finalized or not. And then finalize your antibiotic plan. So optimum antibiotic, the dose and the duration, and you plan on the de-escalation of antibiotic. I'll explain what is de-escalation next. So we are all good in escalating antibiotics. We usually know when to escalate to meropenem and all the broad spectrum. We should usually do it well. But are we equally good at de-escalation of antibiotics? We have to ask that question from ourselves. So what is de-escalation? People have a myth of de-escalation is bad. You are just cutting down or chopping down on antibiotics. It's not the mean. The right meaning of de-escalation is switching to a narrow spectrum antibiotic, which is equally effective and potentially more safe for the patient and for the society. So we are looking at an overall picture here. We are putting an equally safe antibiotics here. And for the antibiotic you had previous, the broader spectrum, narrow spectrum, but they are equally effective. So de-escalation should be looked at case by case. You have to really go to your patient, assess the patient bedside, and plan on de-escalation. If you have a culture report, that's brilliant. That is very easy, straightforward de-escalation, which can be done by anyone. And if the culture says it is sensitive to co-moxiclav, and you have given meropenem, you can easily de-escalate to the narrow spectrum antibiotic with a lot of safety. And then sometimes you have one diagnosis confirmed. Imagine a patient who is you treated with infection, now diagnosed with dengue, and now diagnosed with leptospirosis, and you have been given broad spectrum antibiotics. Now you can either, sometimes if it is dengue, you can basically stop antibiotics. If it is leptospirosis, you can switch to amoxicillin, IV or oral, or doxycycline, and you can de-escalate the antibiotics in such ways. And then, mind you, ladies and gentlemen, one of the most important things that we must do in our clinical practice is IV to oral switch. It saves a lot of life, saves a very cost-effective mode of treating patients. And most of the infections, you need maximum 7 to 10 days of antibiotics. So have that in your mind, and then try to oral switch. I will tell you how we can do it. And initially, we had an understanding that always IV antibiotics are way superior than, so you must treat all the infections as much as possible from IV. But now we are getting more and more evidence in certain infections, oral antibiotics follow on are much safer than continuing IV. There are studies on even some cases of straightforward, uncomplicated endocarditis and prosthetic joint infections. There are evidence coming up. You start with IV and it is very safe to switch to orals. So how can we do this IV to oral switch? So go through these 4 steps and see whether you can do the oral switch. So have the patient is clinically improved, the temperature has settled, it can come to baseline, normal, and you have achieved stability of the clinical parameters and downtrending WBC and CRP. Mind you, I tell downtrending. You don't have to give IV until the CRP or WBC count normalizes. You have to just realize you have had a control, you are controlling the infection. And there should be no concerns of GI absorption. If the patient is on an NG tube or if there are signs of malabsorption, then you can't do an oral switch. But if you're seeing that the patient is eating and drinking and tolerating the meal is fine, so you know that there is good absorption. And then in the 4th instance, you have to see whether there are any complicated infections. So in these infections, we may not be able to switch to oral antibiotic. If there's CNS infection, cystic fibrosis, Staph aureus bacteremia, endocarditis, and empyemas. So in these situations, you might not be able to switch to oral antibiotic. So summarizing all that, think about the 4 moments of antibiotic decision making. These are the 4 things that you should see in your antibiotic prescription. Whether you have made the diagnosis, whether the culture and empirical therapy is correct, and whether you have stopped and narrowed down antibiotics or done an oral switch, and think about the duration of antibiotic. So practically what we can do in the ward is we can do a quick antibiotic round and find out what I suggest is do these 2 things first. Identify patients who are having on antibiotics more than 7 days in your ward, and just identify people who are on meropenem and piperacin-tazobactam. I know that we all are busy in our wards. There are a huge amount of patient numbers. You might be busy with your daily activities, but you focus on these 2 things in your antibiotic round and apply these 4 moments of antibiotic decision making. So this is why antibiotic stewardship there. It has the platform to govern all these principles. So it regulates and optimizes the antibiotic use, and have a surveillance, good grip on how the antibiotics are used, and limits unnecessary prescriptions, inappropriate antibiotic usage, or unnecessary duration. But some people have a misinterpretation that antimicrobial stewardship hinders the efforts to good control infection, but it's not. We are giving appropriate antibiotics and saving lives, improving clinical outcomes. So as a prescriber, what are the roles that you have? We should have the understand AMR and get it into our mind and decide what our role would be individually to counteract AMR. So as an outpatient prescriber, what can we do? So do not prescribe antibiotics in viral illnesses. I mean, you have to have the confidence in differentiation viral from bacterial infections. It needs some practice. You cannot just, it will not come up automatically. You must practice in your day-to-day life, in your day-to-day practice, how to differentiate bacterial and viral and gather those skills. So if you have that skills, if it is viral, you are confident that you don't have to give an antibiotic. And use access group of antibiotics, and you have to refer to that AWARE classification in this area, as Dr. Malika pointed out. And education of the patient is very important. Say it's viral, and it will get better in 5 to 7 days. And usually in outpatient basis, 3 to 5 days antibiotic duration is enough. And as an inpatient prescriber, go through these important facts when you do a ward round, when you see patients. Is the antibiotic chart available in your ward? Has it been actioned? And is it been attached to the BHTs? And then whether the antibiotic chart is filled properly. Antibiotic review is performed or not. And do a quick antibiotic round, as I mentioned before, and identify people who are on broad spectrum antibiotics and also people who are on long durations, more than 7 days, and do the antibiotic review and get help from your consultant or the microbiologist. And if there are people who are on meropenem, a broader spectrum, more effective antibiotic that we have, so after 3 days, just alert your consultant on that. So in hospitals where there is no antibiotic chart is available, we can use the old-fashioned way. We can chart the antibiotics in the fever chart, and we can just write the antibiotics in red, and we can still do the antibiotic review and plan on de-escalation, as I mentioned before. And one of the important things that you can do when you see antibiotic prescription is decide on a stop date of antibiotic when you see the patient. So don't just say openly, okay, just we'll continue antibiotics, but always think about we are going to stop antibiotic on this particular date. Okay, you give 7 days, but also mention, okay, we are going to stop antibiotics on 27th of August, exactly, something like that. So it will refine your antibiotic decision making. What can we do as a leader if you are a consultant or a matron or a sister in the ward? You are in a leading role. What can we do? We can educate the junior staff, empower them for clinical assessment and antibiotic review. And think about infection control. Sometimes as physicians and doctors, we sometimes overlook infection control. We are having patients with MRSA, ESBL, and multi-drug resistant infections, and we might not do, good infection control. Mind you, these patients spread this, we ourselves spread these infections from one person to the other, and that person will need the broader spectrum antibiotic, and that person might lose their lives as well. So think about infection control and collaborate with the infection control nurses and the teams and do this job right as well. And also support a non-judgmental environment. It's very important for antibiotic stewardship. You are basically liaising with different groups, the microbiologists, the other finer specialties, the ENT, cardiothoracics, so all the specialties are involved here. So it's very important to have a non-judgmental environment. Have a discussion with the colleagues and think about the best antibiotic plan on the best interest of the patient. And support authorization of broad spectrum antibiotics. Refer to the AVR classification and how are these antibiotics authorized and support that. And what can we do as an administrator? So support the national program, support the awareness programs and educational activities, and be brave and have an antibiotic stewardship committee in your hospital and be engaged in monitoring antibiotics. And so in that way, if you don't have the data, you cannot drive this forward. So have the backup data, get the pharmacist involved, get the other teams involved, and monitor the data and reassess yourself, your antibiotic choice, prescription pattern also. You can monitor yourself and then give feedback to your colleagues and to yourself and become better every day. Antibiotic stewardship and the prescription role of antibiotics, you cannot just learn it overnight. It needs a lot of expertise, it needs a lot of practice, and it needs a lot of thought and clinical experience. So think about as separate aspect in your clinical duties day-to-day life. And also support collaborative working environment with the ward team, microbiologists, pharmacists, administrators, and also your junior staff, and congratulate them when they have done it right. So in summary, think about the 4 moments of decision making. I will emphasize that again because it's very extremely important. So first, make the diagnosis right. And second, the cultures and the empirical choice, whether this is right or wrong. And third, whether you have stopped or narrowed down the antibiotics, whether you have switched to oral. Remember the IV to oral switch. And then decide on the duration of antibiotics. Don't openly say, just continue antibiotics. Just give a stop date, okay, 7 days completion from the beginning of antibiotic, and then finalize your antibiotic decision making. So think about this. AMR has no boundaries. It will affect anyone, everyone. You are not immune against AMR, even if you have a good antibiotic practice, because it spreads from one person to the other. AMR, MRSA, ESBL, everything can spread one person to the other. So it's like an infectious disease. So it's duty of everyone to attend to this. Thank you so much.
Thank you, Dr. Fonseka, for that very interesting and informative talk. So we'll have the questions at the end, and we'll move on to the third speaker of the CME program. As we know, all of you in the audience, we prescribers, we are actually pertinent to different fraternities in medicine. So next we have a surgeon. So let's see what the surgeon's role in antimicrobial stewardship is. Our speaker is Professor Ishan D'Souza, Professor in Surgery at the Department of Surgery, Faculty of Medicine, University of Colombo. Over to you, Prof. Ishan.
Yeah, no problem. Yeah, but- Accidents of being unable to learn to. Good afternoon, Malika. Good afternoon, ladies and gentlemen. And at the start, let me thank Dr. Malika Karunaratne and the SLCIM for inviting me to give this talk. It's actually a lot easier after that very comprehensive talk by my physician colleague. So, I will be speaking on the role of surgeons in antibiotic stewardship. Now, we all know this discovery, right, of penicillin, right, which was hailed as one of the greatest discoveries in science. And by about 10 years later, penicillin was widely in use as an antibiotic. And in surgery, the prospects of using antibiotics for prevention was almost immediately recognized as a possibility. Then came the discovery of sulfonamide, and this gentleman, in fact, went on to win the Nobel Prize in 1939. But see what has happened 100 years later, right? And this was from a Newsweek magazine, right? Where they are saying that antibiotics are no longer effective against killing microbes. That is because of antibiotic resistance. So why has resistance emerged? One reason is the promiscuous use of antibiotics, especially for prevention, and also failure to de-escalate, combination therapy, inappropriate antibiotic therapy, and also patient expectations, which is quite a problem in Sri Lanka because a lot of patients who in fact have viral infections that don't require antibiotics still expect an antibiotic from a doctor. But of course, they can be educated. And then, of course, there is the issue of prolonged administration when the necessity no longer exists. The result is pan resistance of pathogens to all available antibiotics. There are other potential consequences of antibiotics: bronchial asthma, allergies, obesity, type 2 diabetes, GORD, pseudomembranous colitis, and oncogenesis. So that is why these antibiotic stewardship programs assume even greater importance. When it comes to antibiotic stewardship in surgery, the goals are to avoid unnecessary antibiotic use, to reduce resistance pressure, to reduce unnecessary costs, and also to reduce antibiotic-associated morbidity. The objectives include appropriate preventive antibiotic use, effective source control of the infection, avoiding delays in initiation, avoiding excessive duration of antibiotics, and better use of non-antibiotic infection management strategies. Moving on to appropriate antibiotic use to prevent surgical site infection. Way back in the 1960s, it was found that surgical site infection can be positioned